Good afternoon, everybody, and thank you so much for joining today's webinar on virtual consultations, their place in a post-COVID world as we reset and recover back to better. We have 6 excellent speakers for you today, and we're very much looking forward to welcoming them. We'll just wait a few moments as everyone joins us. As people join, they'll be placed on mute, and we will be using the Q&A function for questions today. This webinar is being recorded and will be made available to all those who sign up, and also will go on our webpage. We'll give it a few more moments for people to join us. I urge you to use the Q&A function, please. We'll have plenty of time at the end for questions. So as we've got a lot of content to get through today, I'm going to ask Andrew to open up as chair. Thank you.
Thanks, Ali. Good afternoon and welcome everybody. My name's Andrew Cuff, and as Ali introduced, I'm your chair for today. I work for Connect Health as a consultant physiotherapist, and I'm the head of our MSK service portfolio. Now, I'm really excited to return as chair 13 months after our second webinar in the Connect Health Change webinar series, which was on FCPs in last September, and more recently when I chaired our webinar on quality improvement in January of this year. Little did we know how popular these webinars will become, and we're attracting on average 200 delegates to each one, just demonstrating how popular the subjects that we cover are. The next webinar in our series will cover unwarranted variation in November and mental health in January. And all past recordings, along with the Q&A summaries, can be found on the Connect Health Change webpage. So today's topic is virtual consultations, and we have a very impressive lineup of speakers, and you can find their full biographies on the webpage. Each presenter will speak for 7 minutes, followed by any immediate questions, but we will take the majority at the end. So I do encourage you to post your questions in the Q&A function. So the COVID pandemic resulted in a rapid expansion of virtual consultations in primary care, secondary care, and in community care. And although virtual and telephone consultations have been available for a long time, they were not widely adopted. Now we need to better understand how to promote virtual consultations without worsening existing health inequalities, and indeed look at how virtual consultations may in fact help to address health inequalities across the population. Now, I'm sure you're aware it is Bone and Joint Week this week, raising the awareness of the importance of good musculoskeletal health for quality of life and well-being. So to start this webinar, I wanted to provide a quote from a person regarding their experience with virtual consultation. And I borrowed this quote from the wonderful publication, The Doctor Will Zoom You Now. So Maria had a physiotherapy appointment by telephone. She was given a specific time and date, but with only 2 days warning, which was difficult because of work commitments. The phone rang at the allotted time and the session was for 30 minutes. She goes on to say, "I didn't know what to expect. The physio created space to ask how I was doing. I felt heard and I was able to ask questions. It was refreshing. There was no physical contact, and of course she couldn't see me, no visual, but we were able to conduct a shared examination. A normal physio session would be in a crowded room, 5 minutes of instructions, you practice the movement, they pop back after seeing other people and ask how you're getting on. It's rushed. I see about 15 to 20 health professionals a year, but this is the most person-centered session that I feel that I've had." So in this webinar, we were asked, well, what has the sector learned from the rapid expansion of virtual consultations? Are different skills required for remote working? Have virtual consultations widened or narrowed the vast avoidable inequalities in healthcare and outcomes for different service user groups? What about concerns regarding confidentiality, safety and security? And how will virtual consultations help improve access and delivery going forward and tackle the ever-increasing waiting list dilemma. So it gives me great pleasure to introduce our first speaker, someone that I have known for all of my career, having trained at Oxford Brookes University at the same time. That's Anthony Gilbert. Anthony is a postdoctoral research and improvement physiotherapist at the Royal National Orthopaedic Hospital Stanmore. We'll be discussing, can you put video consultations in the NHS? So over to you, Anthony.
Thank you very much for the introduction. So I'm really grateful for the opportunity to talk to you all today. As Andrew said, I'm a research physio based at Stanmore, and a lot of what I'm talking about here is based on research I've been doing for my PhD at the University of Southampton. So I've recently finished my clinical doctoral research fellowship that was funded by Health Education England and the National Institute for Health Research. So I'd like to acknowledge them and also my PhD supervisors, Carl May, Jeremy Jones and Maria Stokes. And these are my own views. Can you move to the next slide, please? Thank you. So I spent the last 8 years researching virtual consultations, and much of what I have to say is based on this work. So I've had the unique opportunity, and I probably could say privilege actually, of investigating virtual consultations in the past as an experimental, hypothetical mode of practice, which was trialled as part of a programme of research over a few years, which then during the pandemic turned into the accelerated implementation, right at the height of COVID. And then finally, my last PhD study looked at the experiences of using virtual consultations for patients, clinicians and healthcare managers. So to answer the question that this presentation is about, can you put video consultations in the NHS? And I completely realise this is a bit of a cop-out, but yes, of course you can, we've done it. But a question I would like to pose to you all is, should you? And then if the answer to that is yes, is when should you? And as might become clear over the coming slides, I don't think the answer to this is a binary yes or no, it's a lot more complex than that. Next slide, please. Something I would like to introduce you to is burden of treatment theory, if you haven't come across this already. When we think about burden, certainly in the context of patients, we need to think about patients' capacity to be able to allocate resources to care. And we need to think about the demands of the care that we put on them as well. Burden of treatment theory is a sociological theory that explains patient experience. And when we think about introducing video consultations in the NHS, burden of treatment is relevant. If the demands of care exceed the capacity to meet these demands, patients will experience burden of treatment, and we can assume that treatment burden will lead to suboptimal experience and suboptimal outcomes for the patient. Next slide, please. So if we put ourselves in the shoes of a patient for a moment, just try and visualize someone in your mind. Perhaps a patient with lots of different problems, a patient who has competing life demands, a patient who's got pain. And let's think about the narrative of self-management. MSK problems are complex, and there's a lot of stuff that a patient can do to help themselves, right? So self-management delegates work to patients. I'm not saying that's a bad thing at all, but it is a thing. And I often reflect on the complexity of the patients we see at RNOH, and I'm sure you see, in the services you work in. Our patients have often been through the system, they've been to primary care, secondary care, and then they come on to us in tertiary care. And a lot of the complexities can be around the standalone orthopaedic problem, but then there are other things too. Comorbid long-term conditions that can't necessarily be cured, but they still need ongoing management. And self-care comes into it even more then. And we add into the bucket of workload that the patients have, on top of their MSK problems, there's a lot that they need to be dealing with. And I want to ask you, what is a good self-manager? We have people that adhere to their treatment regimes, and that's really good. And then we have people who are non-compliant, and that's not so good. And I reflect on the language that I've used in the past about non-compliant patients and how I've sort of seen that as quite a negative thing in the past. But let's think about patient experience through the lens of burden of treatment theory, and then this idea of minimally disruptive medicine, which is healthcare that considers the work of being a patient, designed in a way that seeks to minimise treatment burden. We need to consider the sort of things we ask patients to do, and then think, what are the sources of burden? It's hard enough to manage MSK problems and comorbidities, but then if we start to introduce video consultations, how might that be burdensome for patients? Next slide, please. So a lot of my research is around patient preferences. That's what I've studied for my PhD. In the context of my research, it defines preferences as a process called a total subjective comparative evaluation. They're total because the patient needs to weigh up a lot of information available to them, and that's really what my research has been about, identifying factors that influence preferences for video consultations. It's subjective to them, it's comparative because they compare the alternatives, and it's an evaluation because there's an appraisal of benefits. And a patient will prefer the alternative that brings them the most utility or benefit. And rational choice theory suggests patients will choose the option that is most beneficial to them. So thinking about giving a patient the option of a video call or an in-person call, what is a patient going to prefer? Next slide, please. Some of the factors I found that are really important to patients around their expectations of the benefits and what they believe will be the best option, how they see video consultation shaping their relationship and the interactions of their clinician. For some patients, it's absolutely fine, but for others, they see in-person care as more beneficial. The clinical problem. We know MSK problems can flare up. One day things can be great and they can tolerate an hour-long car journey to come to clinic. Another days they might wake up and they can't make it. Their kids might have a class assembly on that day. They might have been caught up in the fuel shortage. The context for preferences is situational, and we need to understand that. Each patient is unique. Do they have the equipment, the broadband speed? Do they have space in their house to be able to demonstrate the exercises? Is their house a safe space for them to actually do their care? Is it confidential? Do they work in a job where they would need to take unpaid leave for an in-person consultation because they've just started a 0 hours contract and they're not entitled to paid benefits? Is the only appointment in the morning and they can't afford the peak train time? It's not just resources for their care, it's resources in life that will create a trade-off with other factors. And as we've seen during the pandemic, some patients can use video calls and it's worked really well. Some patients can't, and there are valid reasons for that. The majority of virtual consultations in my organisation has always been phone calls, and that's been pretty similar as far as I can understand in some other places. Phones are a technology we have available to us. Video might be better to visualise, but if the tech crashes, or if the interactions are impaired, or if a patient doesn't have the most up-to-date phone software or whatever it is they need, their ability to implement it can be affected. And then for a total subjective comparative evaluation, patients need to consider the consequences of the alternatives to be able to determine what is their preferred option. But that's not it. We need to think about what a clinician wants, then about what the organisation wants and what their policies are. Then we start looking at the direction of healthcare policy, like the NHS long-term plan, which has set the vision for the next 10 years. Digital is central through that. And although a patient might prefer an in-person consultation, we need to consider the balance of power at play here and how our biases might impact patients and how they see the world. We saw pre-COVID, there wasn't an option for video calls in many places, quite often down to commissioning concerns. And we saw during COVID, there wasn't really an option for in-person consultations because of infection control concerns. And these are both perfectly valid reasons, but I do need to think about how we can consider patient preferences and our pathways. Next slide, please. So can you put video consultations in the NHS? Well, as we've seen during the pandemic, yes, you can. And I believe it's one of the many unbelievable great successes within healthcare over the last 18 months. But I think the next question that we should be asking, and it's not one I'm necessarily going to answer, is should you? And if the answer to that is yes, then when should you? So I'm going to be quite irritating and leave it there for you to consider that, if that's all right. If you could go to my next slide, my contact details are on there if anyone would like to follow up with me on any questions. And I'd like to thank you all for listening, and I hope I've kept to time. Thank you.
Excellent, thank you, Nancy. You are perfect with time, which makes my job very easy. Take notes, forthcoming speakers. So you mentioned there, Anthony, regarding having the right tools, the right infrastructure in place to enable choice around virtual consultations. Do you think there's different skills required to have a successful video consultation as opposed to face-to-face or telephone, both from the perspective of the clinician but also the patient?
Yeah, I mean that's quite a broad question, but there are definitely some skills that are needed on both parts. I mean, just even simple things like the interactions that you might have. I mean, patients have told me, I mean, I've conducted over 100 interviews, part of my PhD, and what has come up quite a lot is actually that notion of trust and trusting what's going on over a screen. It's a very different interaction over a screen. So even simple things like when you're talking, I mean, I've got two screens up here, so you know, my notes are on this screen, and then I'm looking at Andrew, you're over here, and if I'm having that conversation, it feels to me like we're talking, but a patient can only see my ear or my jawline, or you know, whatever. So there's ways that we can interact that would help patients to get on board and engage. We need to accept that when we're asking patients to do things, I feel, that we're delegating more work on them. So the whole thing about getting them to assess themselves, they might not understand necessarily, and this is a generalization, but they may not understand what it is that they need to do, and we probably need to give them a little bit more upfront knowledge about what it is that they'll need to do during their consultation. And you know, I think taking a step back and thinking what is the best, what is the best thing for this patient in this particular time, and having more of a two-way conversation about that, rather than having set pathways which will be this thing or the next thing. And I think if we start thinking about skills and looking at auditing skills that patients have and what patients may need, and developing resources and sharing these resources across physiotherapy or MSK, I think that'll be really helpful too. So my initial thoughts.
Excellent, thank you, Anthony. And the premise of time, I can see some questions coming in, but we'll pick those up at the end. So now I'm going to bring in our second speaker, a friend and colleague, Gail Sowden. Gail is a consultant physiotherapist, and she is the National Head of Pain for Connect Health, and combine this with an honorary research fellow role at Keele University. And Gail will be talking about the role of blended care in service delivery. So over to you, Gail.
That's great. Thanks very much, Andrew. So within our pain services in Connect Health, like many services across the UK during the COVID pandemic, we have been providing a combination of telephone and video consultations, some online accessed care, but also some face-to-face care. And obviously, we're starting to think about what the future might look like in terms of what we offer and the place of those different components within what we offer. So I've been doing a little bit of work recently looking at blended care, and so that's the topic of this presentation today. Next slide, please. So what is blended care? Well, there's lots of different definitions and descriptions, but they essentially all involve an individual patient accessing care online with the addition of direct contact with a clinician. And depending on the definition, the direct contact with the clinician could be via video, telephone, it could be face-to-face, or it could perhaps be via a platform, and that could be asynchronous or synchronous contact. Next slide, please. So there are some suggested criteria for blended care. So the first one is that all components should combine substantively and procedurally to the treatment process. So they shouldn't be standalone or parallel treatment pathways. Components should be carefully selected and adjusted. So we're really trying to move here towards individualised or personalised care. And that should take into account not just the treatment processes, but also the progress that the patient is making. So ideally, these components should be dynamic and flexible. Of course, in some circumstances, patients might access a preset package of care. They should capitalise on the evidence-based features of both, so very much trying to bring the best of both together, and very much a case of the sum being greater than its parts. And it's really trying to bridge that offline-online treatment divide. It can help to maximise, so the kind of blended offers can help to maximise the use of the clinician and patient time. So, for example, patients could be accessing and progressing with online components in between clinical contact, and that can help to maintain engagement. It can also mean that some of the more time-consuming tasks or self-paced activities could be done outside of treatment sessions. And in some cases, it can help people to access care whilst they are waiting for some clinician contact. So they might access some online intervention first. And that can, of course, reduce waits and potentially help with engagement. And I guess this very much reflects modern life. It reflects the interconnected and often complementary ways that we navigate our digital and our physical lives. Next slide, please. So one of my co-presenters today has done quite a lot of work. So Gilbert et al. Have done some systematic, or a group of linked papers, one of which was a systematic review and qualitative analysis of virtual consultations in orthopaedic rehabilitation settings. And they're actually looking at the work of being a patient and how that linked with patient preferences, as he suggested. And so whilst this wasn't a review of blended care, I very much think this concept of the work is relevant here. and not just the work of the patient, but the work of a clinician. So we know that very much different skills, different processes, expertise, logistical and environmental considerations are involved when it's telephone or video or in person or by accessing an online intervention of some kind. And as you suggested, the positive and negative consequences of this and how patients and clinicians experience this can impact what subsequently happens. It can affect what they choose in terms of preferences. It can affect the ability to engage and their subsequent preferences. So very much need to keep this concept of the work involved, not just for patients, but also for clinicians in any pathway we design to ensure successful implementation, as well as considering this and deciding what we provide to an individual patient. And that, of course, might need to reflect not just patient choice, but what's clinically indicated and what they're able to best access. Next slide, please. So I'm aware that there are tools that try to assess the burden of treatment or the individual's fit for blended care. So, for example, there is the Fit for Blended Care instrument, and that can be used by clinicians to shape a dialogue or a conversation with their patients and to help elicit solutions needed to design an appropriate blended treatment for a particular individual. And I guess in all of this, we are trying as much as we can to be bespoke and individualised, and I guess we need to be thinking about shared decision making and perhaps shared decision making tools that not only talk about the content of an intervention, but also how the process of receiving that intervention and the work perhaps involved in it to help patients have informed choice when they're engaging in care. The next slide, please. So there's a huge amount that we don't know in this area. Blended care is very much in its infancy. There is much we don't know. So, for example, it's unclear what is clinically appropriate and acceptable to different patients. It's not clear what blend works best for whom and why. And this, of course, can make it challenging to understand what the likely return on investment will be in developing and implementing blended offers. It can be challenging to know what the likely uptake is going to be and what the likely outcomes from those different offers is going to be. And we absolutely, to Andrew's point, need to make sure that whatever we're providing doesn't exacerbate or create new inequalities. And again, it's challenging to always know exactly how we would know if it was creating new inequalities or not. And with any change or subsequent iterations of something, we absolutely need to think about how we bring people along on the journey. So how we bring patients and staff and help them to keep pace of any change and to remain engaged with what's being developed or implemented, and to have them, of course, co-create that in the first place. And then what other changes might be needed for transformation to stick? So there might be legislative changes that might be needed, or changes in equipment or pathways or how services are configured. Next slide, please. So what can we do now? Well, we can certainly focus on clinical outcomes from whatever we're providing. We need to evaluate it as best we can, trying to get a sense of which patients are accessing it, trying to describe it accurately, and then evaluating it in terms of clinical outcome and patient experience, but also staff experience, staff feedback. But we need to go beyond just clinical outcomes to thinking about benefit in the widest sense of the word. So ease of access, so thinking about equity and access, flexibility, costs, and numerous other factors that can be important to patients, carers, providers and commissioners. And we need to use shared decision making, incorporating patient choice and clinical indicators to agree the balance between these different components, as well as the level of clinician involvement. Or in some cases, the patient might work through one of these pre-designed treatment packages. But absolutely need to co-create, innovate, and of course, evaluate and share the learning as we move forward in our understanding of blended care. Next slide, please. So this is not my quote, and I'm not entirely sure the source of this, but I think we should not close clinical doors. It's very much about, digitally enabled care, not replacing face-to-face care. So we need to keep clinical doors open. We shouldn't close them in order to launch digital care, but have open doors and accessible online and e-health care. Thank you. That's my last slide. Thanks.
Excellent, Gail. Thank you very much for that, and well kept to time there. In terms of blended care, you talked towards the end there about outcomes and evaluation. What does the published evidence say around blended care effectiveness and efficacy at the moment?
Yeah, so there isn't a lot of literature on this, and much of the literature that exists relates to mental health. So particularly IAPT have published some papers on this, and there is some evidence to support pre-post changes from blended care offers compared to usual care or waitlist controls. There's also a paper that where patients accessed online components before they came through to face-to-face care, and 20% of the patients were recovered using the kind of IAPT definition of that before they had their first face-to-face contact. There is other papers that suggest face-to-face is preferable, so there's a bit of a mixed picture. There are also, of course, a number of other studies being published. So thinking about my area of expertise, which is particularly around pain or persistent pain, there are a number of clinical trials published relating to clinician-supported online care, or packages which might fit the definition of blended care, but perhaps haven't described themselves as blended care. So there's there is quite a lot of literature there. And a mixed picture again. Some shows equivalence compared to face-to-face care, some shows superiority, and some shows inferiority. But I think it is important to keep that broader definition of benefit in mind, not just clinical outcomes, ease and access and equity and cost and all of these things. And one of the challenges of blended care is that if we are very much sticking to the idea of it being truly individualised and personalised, it's challenging then to make sense of outcomes there, because we may have different people accessing care, what they're accessing in terms of the total package may be different, and so it becomes more and more challenging to try and figure out what works best for whom, but we certainly need to try and move in that direction.
Brilliant, thanks, Gail. So quality in its broadest sense, and looks like a kind of an emerging field. Thank you. So I'm now going to move on to our third speaker, which is JP Gowland. JP is a physiotherapist with a clinical specialism in the upper limb. He's an academic tutor at Sunderland University and a founding member of the North East Musculoskeletal Society. Just before I hand over, I do want to remind you that the Q&A function on the right-hand side of your screen is there for questions. And if you look, there's a little thumbs up button where you can upvote questions. So if you agree with the question, be sure to upvote it and we can take them in the Q&A as a priority. So without further ado, I'm very excited to hear JP talk on the management of age-traumatic shoulder pain via virtual group consult. So handing over to you, JP.
Thank you, Andrew, for the kind introduction there, and thank you for inviting me here to speak to you all this afternoon. Could I have my first slide, please? So as Andrew's just said there, my name is John Paul Gowland, and I've been asked to share our services experiences of using virtual group consultation during COVID and beyond. And I'm going to focus on the atraumatic shoulder pain session, as that's the session that I was leading on. First slide, please. So for anyone sitting there in the audience thinking, well, what on earth is group consultation? It's a care delivery model where several patients with the same condition are seen at the same time by one or more clinicians, and they're becoming increasingly popular in the NHS, particularly in primary care, to help manage chronic conditions such as diabetes and COPD. So an example I use when explaining group consultation to someone for the first time is to think of a busy physio clinic. So my morning clinic will have 8 patients in at 30-minute intervals, and let's just think all those patients have turned up with a traumatic shoulder pain, which can happen at times. Now, those 30 minutes, potentially the patients may feel rushed because there's quite a lot to cover on this topic with them, and the patients are going to bring up the same questions often, and they're also going to be given quite similar information by myself. So my kind of question is, if we used a group consultation one 90-minute appointment for all the patients to attend together, could we enhance the patient's care? Could we improve patient outcomes? And could we make savings efficiencies as well? Next slide, please. So the quick answer to that question, when we look at the research that's been done, particularly in diabetes and cardiovascular disease, is yes. There's lots of reported benefits of group consultation. The most obvious being that 30-minute appointments turned into a 90-minute appointment, so the patient has more time with us as clinicians. Some research has suggested that it can improve patient outcomes as well. So this was in diabetes. So patients actually lost more weight when they were being seen in a group consultation. The increased efficiency is quite clear to see, with one GP group reporting a 300% improvement in efficiencies. But one of the key kind of concepts and benefits that I'm interested in is the element of peer support. So seeing patients together and they're able to help each other manage their conditions, which we'll talk about in a few slides' time. Could I have my next slide, please? So what did we do? So pre-COVID, this was going to be a lovely face-to-face session with patients in a church hall, but unfortunately COVID stopped that, as it did with a lot of things last year. So we moved quite quickly to Microsoft Teams as a platform. Patients were invited to attend the sessions if they had atraumatic shoulder pain, and that was from our triage and from telephone assessment. And they were offered initial 90-minute consultation and two 60-minute follow-up sessions over a 3-month period. Now, our outcome measures were taken by our admin team pre-session, and one of our associate practitioners, Mark, would introduce the session. He would help the patients navigate the mute buttons, etc., and how to turn the camera on and off. He would introduce the session, set the scene, but he also would check movement as a secondary outcome measure, but as a bit of a screening tool to ensure that we didn't have anyone with a really stiff shoulder or someone with an arm that didn't move at all. And he would also check the patient's functional goals. Mark would then go on to explore the patient's thoughts, expectations, fears and beliefs, asking patients individually to contribute to the session. He would then gather the questions that the patients had answered, and I would kind of be wheeled out the cupboard to answer those, but also facilitate a discussion with the patients on how we could go together and move forward and help manage their shoulder pain. Patients were provided with education and advice, so we created a YouTube channel. So Mark did the exercises and the patients could watch along at home. A bit of a poor man's Joe Wicks really, but patients seemed to like it. And we also had a patient information leaflet for them to follow. Follow-up sessions were totally patient-led, so it might be 10 minutes long, it might be 60 minutes, just depended on what the patients wanted to talk about. But one concern we had is that patients wouldn't say anything, but we never had a session where it was total silence. Next slide, please. So we asked ourselves a couple of questions. The first, is this effective to manage patients in this way? Because we don't want to do something that's not kind of effective. And the quick answer would be yes. As part of my MSc dissertation, I collected the first 4 to 5 months worth of data, and you could see the results there on the screen. I think something to highlight, which has been touched on, is we had 4 patients that couldn't attend the session. And when I followed that up, that was due to technical problems. So we've got to bear in mind what we've already talked about this afternoon, is that we can't kind of leave patients behind if they don't have access. We need to offer alternatives. But back to whether it was effective. So over the 3 months, we can see that we had a reduction in pain, we had an improvement in functional scores, and as well as an improvement in range of motion, albeit we are aware of the limitations of checking movement over a camera. Next slide, please. Then we asked ourselves, well, is it efficient? So this is where all the managers are sitting upright to see if it's if it is efficient, and the answer was yes. I did a very crude cost salary analysis and looked at our pre-COVID activity and based that on a comparison with our group consultation patients. So on average, we saved around 90 minutes of contact time per patient managing those patients in a group consultation, although they were seen for longer, if that makes sense. And it saved on average about £25 per patient. So if we scale that up across our service, in Newcastle Gateshead, where we're based, we're potentially saving a lot of time and a lot of money. Next slide, please. So finally, the most important feedback. So what did our patients think? So we sent a Microsoft Teams form to everyone that attended the session, and we had about 16 respondents. So out of those 16, 75% would recommend the sessions to their friends or family and attend the session again on a group consultation. 70% felt more able to cope with a condition, which is great, and 65% were able to better understand their condition. It wasn't all kind of positive though. We had a couple of people who wanted a one-to-one private session, and I think what would be interesting is to really kind of delve in and discuss that with the patients about why that was. Back to peer support, so 2 bits of feedback which I thought were really interesting. Other people asked questions that I didn't know I wanted to ask, so clearly that patient wouldn't have got the information that they wanted or needed because they were relying on someone else to ask that, which kind of demonstrates that kind of real peer support that the groups can have. And the comment in the middle there, I realised that I wasn't suffering alone. Now this was verbal feedback, and the lady waited until all the cameras had turned off, and she just sat there to me, Mark, and just said, look, guys, this session's been great. It's not so much what you've told me, but just knowing that there's other people out there. Bearing in mind this was during lockdown too, when social isolation was quite kind of prominent as well. I feel that this is a great tool to help patients like that we can say what we want to patients, but often hearing it from their peers is what they need. So next slide, please. So take-home message, because I'm conscious I'm probably running out of time. Group consultations can improve patient experience and outcomes, but more research is needed in MSK. I'm hoping to contribute to that research base myself with my dissertation, but if there's anyone out there wanting to help a novice researcher, please feel free to drop me a line, because any help would be appreciated. Virtual group consultations, are effective to manage atraumatic shoulder pain, and they're more efficient than our traditional one-to-one care delivery model. But they're a bit like Marmite, so some people will love it and some people won't. But my take-home message to everyone, clinicians and patients alike, would be you don't know unless you give it a try, because change can be uncomfortable. We've all gone to physio school and taught to see patients on a one-to-one basis, and when I asked myself why that was, I couldn't come up with a kind of valid reason. So why not give it a go, audit your results, seek patient feedback, and you never know, you might be doing group consultations in your service soon. Thank you.
JP, that's excellent. Thank you very much. I love that quote. Other people ask questions that I didn't know I wanted to ask. Very much my experience of many things that I attend. So within your service, JP, what are your future plans for virtual group consults?
That's a great question. So it's kind of almost like we've structured the sessions to have that question, because we're very much looking at a blended approach. Virtual group consultations aren't suitable for everyone. People can't access the service, people can't use laptops, people prefer face-to-face, so we're looking at running the sessions face-to-face once COVID restrictions allow. And we're looking at utilising it for other pathologies and other patient groups. So one idea we have at the moment is a seasonal kind of session for people with wrist fractures who, come out of cast that just need that quick kind of support and advice, and that could help with seasonal kind of variations in referrals. But it's not just the upper limb, we're working across lower limb, spinal and complex pain as well. So my colleagues are very busy behind the scenes looking at scaling up these sessions.
Brilliant. So watch this space as the take home there, JP. Thank you very much for your presentation. So I'm going to move us on. And now I have our fourth excellent speaker to introduce. And this is Bhavna Patel. So Bhavna Patel is a life coach, and she's also a health and wellbeing therapist. Bhavna provides valuable and unique insights as someone that's living with both fibromyalgia and complex regional pain syndrome. So over to you, Bhavna. I think you're on mute, Bhavna, if you're trying to speak. You might still be on mute. You're off mute.
Can you hear me?
Can hear you. Yeah, you're coming through. Okay. Thank you very much.
Afternoon, everybody. Sorry about that. Delays on connection. Yeah, afternoon, everybody. Thank you, Andrew, and thank you for Connect Health for Change for inviting me on. Yes, fibromyalgia, complex regional pain syndrome, and various other ailments that are unseen. Single parent of 16 years. At the time they were young children, now they're adults, but in that time I struggled with getting diagnosed, because it's complex. Over the years, the reason why I have become health and wellbeing therapist is partly that I'd like to help my own community as well as other people that are around. I have found it very difficult to be understood, I think, really, and I know other people, other patients and clients of my own have as well. With the virtual side of things, the complications that I've found is I ended up in hospital after trying to talk over the phone in the consultation and explaining what was happening to me. I couldn't show because it was areas that I couldn't really sort of describe on a virtual. And then it got to a stage where I was getting frustrated and it was making my condition worse. I have a left side left shoulder, leg, hip problem, and to be able to describe that over a virtual is very difficult. It needs physical to be seen one-to-one. The other thing is being a carer as well, for my mum, who does have language barriers and who I would have to bring to my house to be able to use a virtual facility. She's found it difficult, and there are barriers there. Now, being South Asian, there are other complications that lie in this where can be helped, but it's an area that I'm looking at as well with another organisation, or shall I say charity, to provide toolkits and toolboxes for the South Asian community. Because I found it difficult in some areas. I want it to be easier and also take that ease off our health service as well. For that, it's a funding issue. If we have the funding, we would be able to provide that service and be able to use our own, to cut language barriers, to be able to help these people more. When it's a virtual consultation, if it's a Gujarati or a Hindi speaking patient, how would you do we have the facilities to be able to find that person, to be able to not translate but to be trained enough and have enough information to be able to comfortably deliver that information? As a patient and a carer with my own difficulties, it has been a constraint on my own mental health where I have to compose. And I wish at the time I had someone to speak to with my own ethnicity. Clinical trials area, I have found that with a clinical trial background, I've been in the NHS myself for 16 years. And when I was in the clinical trials, I found that there was exclusion. Now, as you can appreciate as a whole, we're all intermarriage, we're all, having the free will and evolving from cultural backgrounds, and therefore diseases and conditions are going to be more complex maybe. Have we thought about including clinical trials where other ethnicities and backgrounds are included more? Providing mental health is the root where if we help with the mindset, help with certain elements around that, other things would then marry. I have been through pain management 3 or 4 times. I have done, personally, I have done all the workshops and things that have been given as blended care. There is still areas that can be worked with, and I would like to pioneer or help where I could to put things into place to help the ethnic side of things. So that, again, I actually feel that it would take pressure off if we got outside help in our own communities to be better helping people. I'm not making it just a South Asian, importance, but in general, there are other ethnicities. And if we all have that help, things like complex regional pain syndrome, if I was trying to explain it to my mum, it's been very, very difficult. because they just see it as go to the doctors, you know, why don't you go and get your help? But it's very difficult to try and explain to them what it is, because there isn't knowledge out there that we can translate. And same with clients that I've seen, they've been English speaking, I'm English speaking, but to try and come over and say on a virtual consultation, I have found it difficult sometimes. How can I sort of put my hip and say this is what it is? I was literally swollen at the back of my neck, and I couldn't sort of hold the laptop to put it round to show, because stenosis, how would I show it? You'd have to actually physically prod and prone to be able to see what's actually happening. And I hope that's considered in your researching. Yeah, that's me.
Excellent, thank you very much, Pamela, for your great talk there. And you discussed some very real considerations when we consider virtual consultations, be that telephone or video, language, connecting with community groups, having the ability to describe verbally what is going on. What advice would you have for others who might be offered a choice of a virtual consultation or face-to-face consultation in the future?
Okay, I won't say wrong diagnosis, but the communication virtual is great because you can still see the body language, you can understand where their eye movement is going, so you know how they're talking, their body language in general. You can also see their skin tone. Going on skin tone, I just want to very quickly mention a paramedic, when he came to my house, asked my son, how do you know when your mom's not well? How do you know she's going to have an episode? At this point, I was shaking and clammy and sweaty, and I thought I was having a massive heart attack. I wasn't. I was having a massive thyroid storm. They put me into, going on to what my son was saying, he goes, and he was quite young at the time, and he said, Mummy always said my skin tone might change. So if I go a bit peaky looking, even though we're brown skinned, we can still tell. And I think these are the signs that carers need to see, because in face-to-face they may not know the signs. So if we don't notice it in face-to-face, have we thought about it on a virtual consultation? And also, if we have misunderstood, and I'm going back with a lady that I took recently for dressing her leg, diabetic wounds, she understood what they were telling her, and she was speaking broken English, but I understood her. And I only went there to make sure and ensure that communication was concise, and still the district nurse didn't understand what was being said, even after I translated it. And I think if that was a face-to-face consultation, how would it be virtual? Ended up taking her to A&E because her leg was very swollen, and we were trying to say there is something not right, it's overheating leg. Did D-dimers to put out, exclude clotting. Now, on a virtual, how would we address that, especially with the language barrier, if there was a very big language barrier? Are we going to have people ad hoc or trained people that if the appointment is for 3 o'clock, have we got Bhavna to go and do a Gujarati speaking consultation with us? There is a plus with the virtual side, but there also is, you know, potential of, and I'm trying to be positive and optimistic, and we are in an evolving world. But as you can understand, I'm an English speaking Asian person who is dealing with elderly generation that haven't evolved, or at an age where they're not going to understand what a mouse is. They probably think it's got 4 legs and running around, you know, on a funny note. And I'm sort of thinking of my mother here. You know, when I say it's a mouse, she's like, what? How are we going to and deal with this? And I know a way, but we need funding to be able to. At the moment, I'm working with mental health group, creating a manual so it's easy to understand, and I will translate it in Hindi, which is a universal language because of the Bollywood world. So you don't have to spend money on doing different languages. For the South Asian people, one language can be enough. But it's about investing the time. I'm doing it voluntarily at the moment, you know, giving some time to them to do this because it's important. I've been through it, but even I haven't been understood, and I'm English speaking. And I had 2 near deaths and nearly 1 just before COVID. And this is my one time and an opportunity, if I'm given, to make a change, a change in this virtual world as well.
Excellent. Thank you very much for a really comprehensive answer. Lots to unpick and digest there, and thank you for all that you're doing in this space as well. It's definitely going to make a really meaningful contribution. So I'm going to bring in our final speakers now. So we have Devin Elliott, who is a Senior Programme Manager within NHS England and Improvement, currently working on the excellent Best MSK Health programme. And a slight change to the bill, we also have the pleasure of being joined by Melanie Martin. And Melanie is a physiotherapist with an interest in all things digital, a Tupple Fellow, a clinical advisor to NHSX, and a senior manager within NHSX, and also the digital lead for the Best MSK Health programme. And Devin and Melanie are going to be jointly presenting the national perspective. So over to you guys.
Thank you very much for the introduction. Could we go on to the next slide, please? So as mentioned, my name's Devin Elliott. I'm the Senior Programme Manager for the National Team Best MSK Health programme. I'm going to talk a little bit more about the programme, but I won't spoil all of the surprises because we are joining the event in November talking about variation. Let's move on to the next slide, please. So the Best MSK Health programme, it's a fast evolving programme that's looking to take forward not only the long-term plan recommendations for MSK, but also a key focus of the 21-22 operational priorities for the NHS, working in collaboration with GIRFT. The programme is very much aligned with the evolving work that's happening with integrated care systems, and building upon the benefits that came out of the Beneficial Changes programme that was launched during the pandemic. The vision of the Best MSK Health programme is for Best MSK Health for all, supporting people to age well, grow well and work well. However, the challenge is very complex in terms of where we are as a national programme and as MSK services. Next slide, please. I won't go through everything here that's on the slide, but the primary focus at the moment in the national team is the restoration of elective care, but through the lens of improvement. This requires whole system transformation and with a very clear approach to managing risk, demand and capacity across the whole pathway for MSK. And that is essential if we are looking to optimise productivity, performance and patient outcomes. So I will hand over to my colleague Melanie Martin, who will tell you a bit more about the digital focus that we have in the national team.
Thank you very much, Devin, and to Andrew and Connect Health for inviting me. Apologies for being a late arrival on the bill. Some of you will be aware that within NHSX, we've just closed a £1 million award, and I've been busy ensuring that that money is going to get out to the systems to really explore, develop and redesign digitally enabled care pathways. Can I take to the next slide, please? So I'm just here today just to give you very briefly an outline of my role, or NHSX's role, in supporting the Best MSK Health Collaborative. I think we will all agree that digital is a key enabler to the redesign and almost reimagining what good care can look like closer to home for our patients. So digital is working and weaving its way across an end-to-end whole pathway approach that integrates primary, community, secondary care with physical health and mental health services. So really, really important to sort of reassure you that every conversation that the national team have with regards to the Best MSK Health programme, I'm there and everyone there is advocating for the support of digital to enable care, to achieve the vision and high impact priorities of the strategy. And within that, as my role within NHSX, as Andrew said, I'm a physiotherapist by background, so I'm also able to bring a clinical perspective to those conversations. And the principles that underpin the work that I do in NHSX are to digitise, not to digitise for digitising's sake, but to digitise where we add value and impact to all, to connect services and level out the digital opportunities, and also to transform care through that improvement lens, as Devin mentioned. Next slide, please. The digital playbooks, I'll drop the link in the chat as we go on, are a way of bringing to life some of the real world examples where technology is already showing promise and impact along MSK care pathways. And some of you will be in the playbooks with your work, and we invite you to contribute further. But what's important to say is that you can look and browse through scenarios and problems that your services and pathways might be experiencing at various points, and the playbooks can direct you to perhaps have conversations with those that are solving them as we speak. Next slide, please. I mentioned funding. You know, we know that funding is a really, really important limiting factor, but we've just closed a £1 million innovation adoption fund for MSK, and the successful awards will be announced next week. And I can assure you a fair and transparent and robust process has been applied with an expert review panel with lived experience partners, charity sector voice, to ensure that that money is applied and is well spent. It's a precious thing to get right. But tomorrow we close a £700 million bid. I say we, this is NHS England and Improvement, and £250 million of that has been earmarked for elective recovery technology. So I'm going to be supporting many of the bids that come in to ensure that MSK is also represented and supported in elective recovery. So that's happening right now, and many of you may well be involved in bid writing and supporting evidence gathering. Next slide, please. And really, final slide really is to invite you across this audience and beyond, and using our networks, is to share and contribute to a digital MSK community that I'm passionate about growing. If you are interested in sharing a case study, please do get in touch. My contact details are there. A case study that we can feature within the playbook, but also to contribute to a Futures NHS platform, the Best MSK Health Collaborative platform. We're hoping to create a digital MSK exchange forum where we share ideas, successes, failures, and have good conversations about how better digital enabled care can benefit all. I'll pause there. I think that's my last slide, and thank you for listening.
Excellent, thank you, Melanie, and thank you, Devin.
There may just be one last thing. Actually, was there one last slide? I don't want to I suppose really it's just to say that Devin and I are part of the same team, even though we work across organisational boundaries. And the ethos is about integration and collaboration. And without our lived experience partners, charity sectors, industry, and everyone across the digital MSK community, we co-production wouldn't hit the spot. So it's really important to grow that community. So thanks for listening. And there's my final slide, Andrew.
Excellent, thanks Nelly, and thanks Devin. And those playbooks are excellent, so do check them out. And I really like that message around digitise to add value, not just for digital's sake. So obviously it always comes back to, you know, what's your problem statement. Now there was a paper published yesterday in the BMJ Open looking at the COVID-19 impact on the digital divide. And as we know, video consultations aren't for everyone, and some of the considerations we've mused on already this afternoon. Some people don't have technology, some people don't have the connectivity, some people don't have the confidence. What are we doing for those people?
So that paper has shone a very important spotlight on what existed before the pandemic, and which may have in some communities been widened, and that's a great concern to us all. I think what we're ensuring, or we're all trying to do by coming together, is to understand what equity means. What does equal access in a way that it meets the needs of individuals? So I think what we're looking at doing together is looking at, are we offering equity? Is there an equity of offer? So let's make no assumptions that perhaps our older patients and patients from other communities may not want to use it. Let's ask the question first of all. But we do need to look at equity of access, and that's in terms of having access to the hardware, the connectivity, as well as having the opportunity with the skills that you need to use the technology as well. So we recognise on both the side of the clinicians and of the patients that may be invited to use virtual consultations. And I refer back to what I consider Anthony's model answer on this around preference, is we need to ensure there is choice built into service redesign. It's not digital by default, digital first. It's digital through choice, and we've heard that through many of the listening events that I've hosted or attended, is that patients and citizens want choice, to keep channels open for those that can't or don't want to use technology. So it's really important that we look at both the access, equity of access, but also opportunity with the technology, and also motivation. Does someone need some encouragement and better education to use the technology? And I think you've mentioned the power balance. There is a real strong shift of power from the doctor knows best to the patient knows best model, and I'm absolutely behind this. But I think it's really important to go back to, I think, Gail's point that care is to be digitally enabled, not digital first. So my message here is around choice and ensuring that everyone has access to the education, the skills, the hardware in order to take up the offer of a virtual consultation when it's made in the right context.
Brilliant, great answer, Melanie. And I think the take home there for me and for probably other clinicians on the call is not to assume. And too often we apply our own biases, our own preferences to that conversation without giving that person that option of choice. Thank you very much. So we're going to move to the Q&A now, guys. So I'm going to take the questions from those that are published within the Q&A box. So my first question is coming to Anthony, starting back at the top of the bill, and that's a bit of a forward look. So we've talked a bit around innovation and funding today, but Anthony, where do you see video consultations, say, 10 years time?
Well, I would like to see it in use, but appropriately and considerately. And I think a lot of stuff that has come through in the discussions has been that it needs to be an option rather than, I suppose, rather than mandated. But I think to do that, we need to understand where it's best placed. And there's been some excellent research. I mean, I'm coming at this as a clinical researcher, but there's been some excellent research that was conducted and published about video consultations before COVID. And this is something I've reflected on in my own research. Technology really excites some people, but it also turns people off. And if we think about research and sort of how that's informed policy, participation in research is often voluntary, and many of the people in the olden days may have been excited to try it because it wasn't common practice. So things might have been a bit skewed. And also some of the research that has been done doesn't necessarily report a lot of the negative stuff, although implementation science literature is really filling that gap. And if we look at things now, phone and video consultations are mainstream, but we need to not forget how scary COVID was. I mean, let's not forget, lots of places shut their doors and they cancel clinics, and we're all on ITUs, and elective procedures were cancelled, and virtual was the only option. And that's a very different context to where we are now. And likewise, pre-COVID was very different as well. And I'll pick up on JP's point earlier. about research. I'm really biased. You know, I think research is important, but we do need high quality research to help us figure this out. I think one of the main barriers to use is around expectations and people not believing it might be as effective as face-to-face. People that I've spoken to have been worried about what happens if something bad happens. Will patients sue us if we don't get better? There are all sorts of issues, and I think high quality trials are needed to answer the effectiveness question. And you know, the best MSK health stuff is really important. It's linked to GERFT. I work with Tim Briggs at RNOH, and I've heard him say this many times, and it's completely bang on. We need to work with data. And I'd ask, you know, anyone on the call who's experienced this and what data have you collected and what we're doing with our data. And I suppose I'll put this question to Mel from NHSX. How can we build national infrastructure to use data to shape the future of video consultations? So I think it could be really good having video consults. I truly believe that. And I think it has the potential to transform the lives of MSK patients in 10 years' time. But we've got a lot of work to do to collectively maximise its potential and figure out where it's best suited. So I think what happens in 10 years depends on what happens over the next 10 years from us as MSK professionals working with our colleagues to make it work best. That's a really long answer. I'm so sorry.
Brilliant. No, that was a great, very comprehensive. And actually, I'm going to bring in JP now, because I think I'm going to bring a couple of questions from the chat, one from Katie Napson, which was around preferences, and how can somebody have a preference for a video call if they've never experienced one before. The original question was for Anthony, but I just want to kind of segue that into your impressive attendance figures within the virtual group consult. And so you're combining both the novel aspect of being virtual, but also the novel aspects of being a group consult, and seemingly have done that well. So what are your thoughts on informed preferences?
Well, that's a very good question. So just to take the point about the attendance rate, so we're probably falsely kind of low because patients were kind of called the day before the session to have data collection, outcomes taken, etc. So they were kind of a reminder service there. So I also think we were dealing with patients in lockdown, which was a very unique situation. So this was the only option we had. So patients had been sitting on shoulder conditions there for months and months, and you know, we kind of dangled a virtual consultation, you know, we'll take it. So I think kind of the DNA rates are maybe slightly falsely low, but it's a good question again about preference, and it goes to trialing the sessions. So our patients are sent an information video just explaining what the sessions are, you know, telling them what's going to happen, making sure they realise they'll be with other patients, but we'll also tell them the benefits of those sessions. And then we give patients the choice. So if they kind of join in and you use your kind of your non kind of verbal communication skills, and you can just sense if someone's not enjoying it, and you can say, look, you've tried it, would you like to have an alternative and come in to see us? So I think it's about trying new things, but also you know, we can't kind of make people kind of join in, if that makes sense.
Excellent, thanks JP. And yourself and Nancy have both reflected on the question around effectiveness, and I can see that Carol and G in the chat have also asked questions around effectiveness. I think it's really important that we don't stifle innovation. If we wait for the randomised trial that demonstrates it is better than the control, then we can sometimes be a little bit behind the curve and not harness the potential. And the idea of an audit or a service evaluation as that first step, proof of concept, is really excellent. And as we grow and we look to kind of build this across the nation, and that brings me back to Anthony's question that you kind of poised to Melanie, which is around what are we doing around national infrastructure and particularly data to support embedding video consultations or virtual consultations throughout the healthcare system.
Okay, well, the first thing I'm going to do is acknowledge that's a huge question, which I can't provide an entirely whole answer to. I suppose I'm going to break it down into what I know we are working on, and we as the national team with data analysts and experts from informatics who are embedded across the Best MSK Health programme. I think if we're doing that well in a national MSK programme, we can be make a reasonable assumption that for other long-term conditions, things are progressing well also. So I'm going to talk about the Best MSK Health programme in that context of data collection. As a physiotherapist and an observer across this programme, we haven't collected data well over the years. We haven't been able to take the data where our patients have gone. So what I think we're really now starting to do is to aggregate data, standardize what we all want to learn through data collection, and put the shared responsibility between both the patient in the form of collecting patient-reported outcome measures, which I think is much more mainstream now, and also experience measures, and linking it to what adds that greatest value. So linking it back into the high impact strategy recommendations and outcomes, so that we have a data work stream that is looking across Best MSK Health and saying, well, what do we want to collect? When do we want to collect it? Who needs to provide that data? What will it tell us and what will we do with it? So it has real meaning and it really has a traceable sort of value to the patient's care. That's what's new for me. I didn't see that 20 years ago, 10 years ago when I was working as a clinician. So I think we are doing that. The problem, of course, we still all face is, well, how do we get the data from point A to point B when the patient moves from primary into secondary care and across primary mental and physical health services? I think what we're starting to see is there's more patient-held records, patients using technology where they take their data with them, and it's starting to be integrated into primary care held records. But I think there's still a long way to go in that interoperability piece. But integration of care and data is very much front and centre now, where I don't think it was in the past. And it's underpinned by greater trust in the use of technology. I think it's coming. And I think also trust in what data needs to be shared that will help my care. So me as the patient. And I can share an example of having co-designed and co-delivered a service across the South East London integrated care system myself, with a team, of course, with patients, designed for patients. They told us they trusted to share their data if they knew what we were going to do with it, and if we showed it back to them and how it was impacting upon care. So it's not just about what data, it's about when and how to collect it in a way that's trustworthy for patients. And then we're still working on that piece of making sure the data travels where the patient needs to go. So we've got some examples of that working well, but it's a little bit siloed and broken up. But the Best MSK Health programme are definitely onto this, is what I would say.
Excellent, Mel. Thank you very much for that. And I think we all reflect over the last 12 months, we've seen the value the data's played in the daily briefings with COVID, what that meant in terms of understanding how we've responded. So hopefully that message is getting out there within the public. And that message around giving the data if we know what you're going to do with it. We see the similar kind of conversation with clinicians with collecting proms, don't we? Of, well, why am I collecting proms if I don't see the outcomes? So really interesting. I think might be the final question of the Q&A, and I'm going to come to Gail. So to just get the kind of persistent pain angle on this discussion, particularly when we think around things like safety or safeguarding, suicidal intent or ideation that might be picked up whilst you're in a virtual consultation. Do you have any experience you might share from a pain perspective, Gail, in terms of how we might navigate some of those issues?
Yeah, sure. Thanks, Andrew. Yes, I guess I'm thinking about things like Teams or the Microsoft Teams or Zoom-based group online programs. And I guess wherever possible, we would try to assess somebody to try and make sure that people were coming through to something that was appropriate for them, and that any risk issues or concerns had been dealt with or could be managed in that environment. We tend to have two members of staff involved on those sessions, and the second member of staff or both members of staff would have access to all the patients' phone numbers and would know the GP phone numbers. And so much in the same way as you might do in a face-to-face encounter, if issues arise that cause concern, a patient, says something, or keels over to the left of the screen or something, that second person can ring the patient and try and check in with them and make sure that they're okay, and follow the safeguarding process if there's concern raised and action is needed to be taken. So I think having that, having the clinicians being aware of who's coming onto the call, and having the access to the patient's contact details so that somebody can call them and just make sure that they're okay, and if not, do what's needed.
Excellent, thanks Gail. And just to confuse the tech team, I'm going to ask one final question, and that's to Bhavna, and particularly to try and round up today's session. Do you feel that the webinar today and some of the points we discussed show that as healthcare clinicians, as leaders, as people that are trying to research in this space, do you feel we're listening to some of the concerns that you've articulated so we can improve the virtual offer moving forward?
On a clinical side, on a clinical research side, is that what you're asking me?
Not just from a research side, but I suppose from clinical care, clinical research, implementation, making sure that we don't have a one-size-fits-all approach to digital enabled care.
I do feel that, well, 50-50, I'd say. There is an area, or there is areas that I found that is exclusion, and like I said, on the clinical trial side, I feel that it should be inclusion. Ask more different ethnicities, because my children definitely are not going to do what I've done. They're going to have intermarriages, and that's going to make complications. For example, if I'm just thinking aloud, Afro-Caribbean, I've got family member that's obviously with my cousin, and for example, when they have children, have we thought about thalassemia and other conditions that intertwine? I would say it has been looked at, but more has to be done. I think there's still more work to be done. Certainly from when I was in clinical trial and coming to today, I do question that has some areas just been looked at, or have they just been surfacely skimmed over? And I think in depth, it's okay, we've got resources, we've got complications, or say finance side, but it's for the future of our children, my children's generation, or their children. We've done our bit, but what about going forward? We're evolving in many other areas, but have we actually specifically looked at certain areas that we've sort of thought, okay, we could deal with that as it comes along, but we need to be prepared for it. Are we prepared for it? In many ways, I would say, and clinical trials, I would say, yes, some pump does need to be happening there, because the world out there is growing very fast. We're going to be left behind if we're not researching into it. Money needs to be given to those areas, and we have to look at it as not a tunnel vision, but an overview. Sorry.
Now, of course, I'll finish there on your final bit about what you mentioned about the future, and there's more to be done, and I think we all agree with that statement, that sentiment. So guys, that could bring the end of our Q&A and the end of today's webinar. So please do fill out the feedback survey. It should take just 90 seconds to 2 minutes of your time, and that will help us to improve future events and understand what topics you would like to see covered. So I just want to say thank you very much to all of the speakers, and also to all of you that have attended the webinar today, and to kind of shape and join in the discussion has been really excellent. And we do really look forward to welcoming you back to some of our future Connect Health Change webinars. So next month we have Unwarranted Variation, and as Devin alluded to, we have Andrew Bennett from the Best MSK programme, and Tim Briggs as well, talking about how can we review orientation and look at this productivity saviour in the future. That takes us into the new year, so a break over Christmas with discussing mental health and are we doing enough, and then into the spring where we discuss health inequalities which are both unfair and unavoidable, and what can we do to address these and narrow them moving forward. So thank you for your time today. Thank you again to the speakers, and look forward to welcoming you back to webinar sometime soon.